Welcome to this explainer, where we're mapping out the clinical pathway for managing invasive Candida infections in the NICU. As neonatologists, you know that despite all our incredible advances in intensive care, invasive fungal infections are still this massive, persistent threat to our extremely low birth weight and preemie infants. It's a high-stakes pathway where literally every single hour counts. So let's jump right in and map out exactly how we can protect our most vulnerable patients.
Here's the roadmap for this explainer. We're going to cover the neonatal Candida threat, identify key risk factors, dive into prophylaxis strategies and protocols, walk through diagnosing disseminated infections, and finally, targeted antifungal treatments.
All right, Section 1, the neonatal Candida threat. We're looking at baseline colonization and prevalent pathogens.
Consider this staggering figure for a second. By just 1 month of age, nearly 75% of infants in the NICU are colonized with Candida species. 75%. This colonization usually stems from vertical maternal transmission during vaginal delivery, which makes sense when you consider maternal colonization can hit nearly 70% in the third trimester. So if your patient develops an invasive Candida infection within that first postnatal week, you're almost certainly looking at vertical transmission. And unfortunately, as we all know, early onset carries a much, much higher mortality rate. This baseline exposure really sets the stage for everything we're about to discuss.
Now, what exactly are we fighting here? Well, Candida albicans is the main culprit. It's the primary driver of invasive infections. But we also see a lot of parasilosis and tropicalis. Here's the really crucial distinction from what you'd see in the adult ICU, though. Adult typical species like glabrata and cruce, they're super infrequent in our neonates. Keeping this specific microbiological profile in mind is absolutely crucial because it directly informs our empirical treatment strategies later down the line. Moving right along to Section 2. Identifying key risk factors. We'll compare host vulnerabilities against iatrogenic drivers. When we look at risk, we see this really stark contrast between patient-specific vulnerabilities and, well, the things we do to save them, the iatrogenic drivers. On the host side, you've got extreme low birth weight under 1,000 grams and extreme prematurity under 28 weeks as your biggest predictors. Throw in GI disorders like necrotizing enterocolitis that totally compromise the intestinal barrier, and the risk skyrockets. But on the flip side, our life-saving interventions like central lines, third-gen cephalosporins, and parenteral nutrition drastically elevate that risk profile. It really creates a perfect storm for an immature immune system.
Let's connect these risks to the actual mechanisms because it makes the picture so clear. When we use broad-spectrum antibiotics, we're basically wiping out the normal protective flora, which literally opens up mucosal niches for fungi to just set up shop without any competition. Meanwhile, those central venous catheters, they breach the epithelial barriers, allowing Candida to form biofilms on the catheter tips and hitch a ride directly into the bloodstream. And then, if you add parenteral nutrition to the mix, wow, you are essentially pumping an ideal lipid-rich growth medium right into the vascular space, literally feeding the fungus at the exact site of entry.
Okay, Section 3, prophylaxis strategies and protocols. Let's look at some actionable thresholds for clinical intervention.
So when you're making the call on fluconazole prophylaxis for those tiny preemies under 1,000 grams or 28 weeks, the whole decision strictly hinges on your specific NICU's baseline incidence rate. If your unit is hitting that high threshold of 5% or more, prophylaxis is explicitly indicated. No question, you have to protect them. If you're hovering in that moderate 2 to 4% range, you're looking at a case-by-case basis depending on individual risk factors. But if your NICU's rate is under 2%, the guidelines suggest holding off on blanket prophylaxis. In that case, you want to lean heavily on active diagnosis and vigilant monitoring so you're not exposing them to unnecessary antifungals.
When you do pull the trigger on prophylaxis, your primary regimen is going to be fluconazole, dosed at 3 to 6 milligrams per kilogram twice a week for 6 weeks. But what if availability or resistance is an issue? Well, we've got alternatives. Oral nystatin at 100,000 units 3 times a day is a solid choice for infants under 1,500 grams. And here's an interesting one. Oral bovine lactoferrin, dosed at 100 milligrams a day, either by itself or with lactobacillus, it's actually shown to be pretty effective at countering the risks of fungal translocation in the gut. It's a really great tool to have in your preventative arsenal.
Let's move to Section 4, diagnosing disseminated infections. We'll go over the mandatory clinical reflexes and evaluation. I want to challenge your clinical reflex for a second here. Imagine you're on shift and you get a positive Candida blood culture for a 750-gram neonate. What are the absolute mandatory steps that must immediately follow? Think about how aggressively this pathogen spreads when the patient has a fundamentally immature immune system and practically zero innate barriers. What's your next move?
Well, here is the required sequence. Because neonatal Candida loves to aggressively spread to critical organs, guidelines strictly mandate an active evaluation for dissemination. Step 1, you need sterile blood and urine cultures immediately. Step 2, you absolutely must perform a lumbar puncture because CNS involvement is a massive threat here. Step 3, get a dilated retinal exam to rule out endophthalmitis. And finally, Step 4, get thorough ultrasound imaging of the genitourinary tract, liver, and spleen. You have to map out any systemic spread. Because honestly, you can't treat it effectively if you don't know exactly where the fungus is hiding.
Right alongside that diagnostic mapping, you have got to achieve source control. This is absolutely crucial. You have to pull all potentially contaminated medical hardware, especially central lines. Why? Because Candida forms these thick, impenetrable biofilms on synthetic materials. These biofilms are notoriously tough for our antifungal drugs to crack. If you leave the hardware in place, you are basically leaving a protected fortress of fungus hooked up directly to the infant's bloodstream, which completely sabotages your pharmacological efforts.
Which brings us to our final section, Section 5, Targeted Antifungal Treatments. Let's look at primary and alternative regimens.
Once you know the site of infection, your treatment selection becomes pretty clear. For systemic or CNS-involved infections, conventional amphotericin B deoxycholate at 1 mg per kilogram daily is actually the preferred choice in neonates over the lipid formulations. It's kind of surprising, right? But neonates actually tolerate the conventional formulation really well, with a low risk of toxicity, whereas lipid formulations just don't clear the urinary tract as effectively. Now, if it's a non-CNS infection, and the infant wasn't already on prophylaxis, fluconazole at 12 mg per kilogram daily remains a reliable workhorse. Speaking of fluconazole, there's some relatively recent pharmacokinetic data that is a real game changer. Studies have shown that hitting them with a fluconazole loading dose of 25 mg per kilogram gets you to therapeutic targets way faster and, here's the best part, without increasing the risk of hepatotoxicity. When you are battling an invasive infection in a tiny preemie, rapidly hitting target concentrations is literally everything. Using this loading dose correctly is such a vital tool to maximize survival. Now, with the rise of complex and resistant cases, you might be wondering, hey, where do echinocandins like micafungin fit into our standard NICU algorithm? I mean, they're used everywhere in the adult ICUs, right? Well, in neonates, the data is a little trickier.
Let's break down micafungin, which is the most studied echinocandin in our neonatal population. Its biggest advantage? It absolutely wrecks Candida biofilms and handles resistant species beautifully. But its utility as a first-line agent is severely handicapped. First off, it has terrible penetration into the urinary tract, making it basically useless for UTIs. Second, it does a really poor job crossing the blood-brain barrier. If you're backed into a corner and have to use it for CNS involvement because of other toxicities, you have to crank the dose way up. We're talking 10 to 15 milligrams per kilogram per day. Because of those glaring limitations, echinocandins are pretty much strictly reserved as a powerful salvage therapy in the NICU, not your frontline go-to.
So as we wrap up this explainer, I want to leave you with one absolutely critical question to take back to your unit. Do you know your exact NICU baseline incidence rate? I mean, the exact number. And based on whether it's above or below that 5% threshold, are you actually optimizing your prophylaxis protocols to protect your most vulnerable preemies without unnecessarily exposing them to antifungals? At the end of the day, managing this clinical pathway isn't just about memorizing drug dosages.